I said that I'm working in Maison de Soins Palliatifs de Laval and also at Sacré-Cœur Hospital, so it's been 16 years now, and I do 80% of my practice in palliative care. I do also patient at home. So. I'm here today to try to define the existential distress that's really quite a challenge, and the use of continuous palliative sedation. So I have no potential conflict of interest with the content of this conference. And we were going to try to define existential distress, good luck to me, and understanding the loss of identity, knowing the screening tools available and all the interventions that we need to put in place, understanding difference between all the palliative sedation therapies and continuous palliative sedation, and knowing the administration and legal framework and required follow-up, and also the understanding of all the support that you need to do. So the meaning of existential suffering. So despite all the attempts to define it, and really the need, because you've heard this morning that it's really a challenge even to identify it. So people sometimes they don't even notice that the patient is in really big distress. So it remains poorly detected, and even one of the aspects I find that can be neglected in palliative care. So imagine in palliative care it's neglected. In general, of course, it's yeah. So you must make sure that your patient, you must screen for the distress. So I reviewed the literature, and it's 56 definitions. So and the spirituality and existential concepts are often mixed up, so it's difficult to define. But I think the two major themes that I can see is the meaning of life. So defining the meaning or losing the meaning, finding answers. Why me? Why am I here? What's the purpose of life? What will happen to me after death? It's, I think, all questions that we have, but we try not to have during all our life. And one day, bang, it's at the end, so you must answer it before. So that's maybe the problem. And two, the relations with others. We heard this morning also, it's ministry of loneliness. Oh my God. So you know that relations are really the essential for humans. So even if you're alone all the time, and when you're aging, you're more alone, hope, despair, loneliness, loss of identity, fear of being a burden. I hear it so often. I don't want to be a burden to others, you know. So people feel that the society is you're a burden. You're useless. The intense fear, or even the terror to die, I hear it. There's a pretty interesting study from Van Lender. She's from Belgique. She's a psychologist, and in a doctoral thesis, she did a study with the main subject was the end-of-life distress. And she wrote a book about it, and you should read it. It's called The Apport de la psychologie clinique aux soins palliatifs. I don't know if there's an English version, but it's really, really a nice book. The study consists of 26 psychologists that analyzed all the interviews they did over a year, over 300 patients with like 1,000 interviews. And the distress, if the distress is really linked to the transitional period of loss of self, it means that it does not just originate in the fear of dying, as we can think the first, but rather in the feeling of losing our identity. So that's the main thing she wrote. The broken mirror, it's a nice way to understand it. It's from the one of the psychologists specialized in palliative care, Joanne de Montigny. I don't know if you know her, or she's she's a lot active here. And she said that the disease affects the body, and then the body affects the body image, And after that, the body image affects your identity. If the sense of self was basically based or anchored in your body image, you're going to have a big distress. So it's like linked. And we know that today we have a lot of superficial, it's always what you like and what you see and what. So I think it makes sense that there's more distress. It's also the image. Identity is what you think that people see when they look at you, what you're described. So the broken mirror happens at the beginning, even before you're gonna become dependent of others. And the presence of the identity rupture explains the level of distress that you can see. And I'm asking myself, because I can see that maids are more often asked at that time, way before the end. So I'm asking myself, are they in identity crisis? And they have a lot of distress at that time. And we know that we can help them, crossing that. But at that time, they feel like this. So they're in a lot of pain. The Boston and all said that you have existential distress when the existential concerns cause you suffering. And it's really big. It's the nothingness. There's no sense of life. You have the identity crisis and you lost the sense of connection with others. It's really, really dark. Your mindset is dark, and your everything is different. You don't see the life like it was before. It's like everything is nothing. You can feel the people in distress, because when you're going to enter in the room, you feel like you're in the fridge. You're going to feel like you're useless, that he doesn't want to connect. He's going to exchange a genuine communication, but when you're going to try to really connect, he's going to take a step and say, no, it's okay, don't need anybody. So he's really detached from relationships. So if you feel that, you're in front of the existential distress. So there's many reasons stated for wanting to die. We heard a lot: loss of purpose, despair, depression. One of the panelists, they said the depression, suicidal, it's really true. They feel like this, they want to end their life, and it's a suicidal ideas that they have. All the loneliness, the fear of the future, a lot of fear of suffering. And what I see is that when you hear from the radio or the TV, they're always acting on it. They're always saying, you're gonna suffer, you're gonna suffer, you're gonna suffer. So they're using the fear of every human to just say, so just ask, and you're gonna be okay. So it's and fear, it's one of the most powerful emotions. That can do really bad thing in history. So we can see that it's the fear over there. Fear of becoming a burden. So it's really, really big issue. I see it. Some people, they even say the mother, or I think we're going to take maid. You know why? I don't know why. Because it's going to be more casual for all the family to be together. We're going to put it in the calendar. The date and the hours, so everybody will be there. It's his wishes. Okay. See, you can see that now. The loss of identity, I think the study is really clear about it, and it's a nice to. Now I question my patient differently because I read the study. So, and it's very nice, the exchange that we have since then. because they're going to say, yes, it's true. I don't feel myself. The loss of dignity and anxiety. I think it's Dr. Fortin. She said that she's a psychiatrist, and she asked a question or a comment, and she said that it's really important to assess and relieve the psychological suffering, and I'm really agreeing with her, because we're always attempting to assess and relieve the physical discomfort, and sometimes we forget, but the human is a whole. And if you're treating physical discomfort, but you're not doing the psychological suffering, you're going to have physical discomfort. So it's like, it's really abundant. You must do both. Here in Quebec, we have Outil dépistage de la détresse. It's the screening tool for distress. I read that there's something like this in Ontario. I don't know if it's other province. Maybe people from other province could tell me. It's called DART. It's a distress assessment and response tool. Yeah.
We have that in Ontario. Yeah.
Ontario. Yeah. So yeah, I saw it was in Ontario. So we kind of try. I don't know. Do you know since when you have the DART?
I don't know when it started.
Okay.
Like since I started my training, which is over the past 8 years.
8 years? Okay, that's good. Because here in Quebec, we have like this still since 2009, but it's only like recently that we have this kind of tool, and it's not in palliative care team. It's in oncology team. So the next step was to do palliative care team, but we're in 2018, and I'm in a palliative care team at a very different location, and I don't see it. So it's bad, because that's a good tool. You can do you fill out the form, with the patient, and you see. And the interesting thing is that it's from the health minister, and he said that, yeah, it's really important to screen the distress. And here, if you have distress, you have to ask the intervention, so social worker, psychologist, everyone. And you look at this, and it's fantastic. The only problem is that I don't have psychologists. But we can try and ask and tell, but the resources are. There's very little research on the understanding on the means used and the treatments for managing the existential suffering in palliative care. And you know that referrals are really late. So the distress, you can imagine, it can be present from weeks, even months. So we have a time constraint. We're always in the emergency to act because the intensity of the symptoms are really, really high. We must not forget that the natural process is always evolving. So the palliative care patients are always unstable. And patients are often in the actively dying phase. And when we say end of life, it doesn't mean like few hours from death. So it's important to know that if you are at the end of your life, we're thinking about months, weeks or months. And if we're talking about actively dying, it's more like hours or few days. The Collège des médecins du Québec, he said that it's the duty of every attending physician, family doctor, or other specialist to relieve the suffering of patients under his care in the last days of their life. So it's not just the duty of palliative care doctors. I'm at Sacré-Cœur Hospital, and I see a lot of suffering. Someone said this morning, and it was really the violence even with the medical procedure and invasive treatments. And I'll talk about it this afternoon more, but it's really a problem. So existential distress support, you must first screen it, and then try to involve all the stakeholders that will help you if you have, because without resources, of course, you sometimes all alone with sometimes one social worker and the nurse. And if all the interventions fail, and the last intervention that you can use is the intermittent palliative sedation if you have a prognosis over 2 weeks, and continuous palliative sedation if you have less than 2 weeks. So we will explain what's continuous palliative sedation, because it's the one that you have to declare by the law. Okay? So continuous palliative sedation, it's the care that we can use in palliative care, consists of the administration of medication to a person at the end of life at the request of that person or the significant other, with the objective of easing the person's suffering, but by rendering her unconscious. So it's very important, the level of consciousness. So it's the deep sedation that we're talking about, in a continuous manner until death. So continuous palliative sedation aims to make the patient unconscious to relieve the symptoms, because we need big symptoms, refractory symptoms. And if we look at the Richmond scale, you must have the level of consciousness that we need is -4, -5. I will show you what it is. And it's only that continuous palliative sedation that you must report to the CPDP within 10 days after following the continuous palliative sedation. So it's in the law. So that's the Richmond scale I was talking about. It's you can see -4, -5 is you need physical stimulation to have a reaction, and even -5 there's no response to voice or physical stimulation. So we're thinking about deep sedation here. Continuous palliative sedation is often referred as the terminal sedation, and it can be confused because people may think that it's the medication that is terminal and causing the death, but that's not the case. It's the terminal word means the terminal condition of the patient, and the medication, when well administered and well prescribed, only for to change the level of the consciousness. So it's not intended to cause death. It's to achieve deep sedation while the natural process of death is occurring. And you must know that you cannot do it if the person is over 2 weeks of the prognosis from the death estimated. So refractory symptoms, you have it when it's near death, when it's going really sometimes bad, and the patient is actually actively dying. So instead of suffering the extreme symptoms and suffering like this until the death occurs, it's the objective of the doctor to, with the agreement of the patient, of course, to change and the level of consciousness and render him unconscious on a continuous basis until the death occurs. In my opinion, this is the clearest article I've read on the subject, so I have it in reference at the end of the presentation. So if you didn't know, just go and read. It's really good. Other reference documents here, we have La sédation palliative en fin de vie from Collège des médecins, and we have also the recommandations québécoises from the Société québécoise des médecins en fin de vie. Continuous palliative sedation should not be confused with two main things. First, the decrease of level of consciousness in connection with the natural process. We know that we're not dying with, level of consciousness normal, and sometimes you see that he's losing consciousness until near death. And also we call it the secondary sedation. It's the side effects of commonly used medication in palliative care to ensure comfort. So if you give, like, let's say, midazolam for anxiety, and there's a side effect of sedation, of course, you're not doing palliative sedation. It's just side effects. The rise also, sometimes they think that because I rise the level of morphine and they are more sedated, then some people, they confuse it. So palliative sedation must be used with certain conditions. The first one is to have refractory symptoms that do not respond to usual palliative treatments. You must use appropriate sedative drugs. We'll see the drugs used, and carefully titrated the sedation until you see that the symptoms are gone. So sometimes it's not, he's just sleepy, but every bad symptoms are gone, so it's okay, you will let the patient like this. The continuous, it's really the deep sedation, as I told you, and you must declare it. If you do a continuous palliative sedation, it's very important to monitor the level of consciousness of the patient. Why? Because that's the objective. The objective was to render him unconscious, because the way he's not comfortable. So if you have to check him or the nurse every 15 minutes, make sure that the level is okay, and if not, to adjust the medication. Never forget the natural process, because if you start a palliative sedation, not the continuous one, but a palliative sedation, and he's sleepy a little bit, and maybe 5 days after he's unconscious, you didn't increase the medication. It's just a natural process. Of course, it's not a continuous palliative sedation. So that's mainly the refractory symptoms that we must have, or that we have, that will decide, or the doctor will decide to do that with the agreement of the patient. So when you have a big agitation, uncontrollable, or breathing distress, convulsions, severe pain, secretions, bleeding distress, nausea and vomiting, existential distress also, if it compromises the achievement of comfort. The other condition I told you was to be with a prognosis under 2 weeks, because you know that if we put the patient under medication and he's unconscious, of course he won't be able to hydrate himself. So when you start continuous palliative sedation, you have refractory symptoms, and the patient already stopped by himself, by his own, the hydration, and he's not eating since a few days or weeks. So it means that he's actively dying, so you're not changing the prognostic. In existential suffering, we must be very careful, because the patient may not be under 2 weeks. The prognosis can be longer than that. So what you're going to do? You're going to have all the interventions with social worker, psychologist, if you have. If not, you're going to try with the intermittent. You can ask if you want that. It's intermittent sedation. So what it is, it's you're going to put the same medication with deep sedation, but only for 1-2 days. And then you're going to decrease and sometimes stop the medication and see how is he feeling. Sometimes with the rest, that kind of rest, the patient feels better. Sometimes not. So if it's not good, still not good, you must again evaluate the prognosis. And you can say, okay, we're going to do 2 more days and we'll see. So we do it like this, and Of course, when they feel like this, and I can see them at the end, so it's not lasting for 4 months like this. It's pretty difficult with existential suffering, like when you have a prognosis of 6 months to 1 year, because you won't do intermittent sedation for 6 months, of course. So yeah, it's difficult. So probably that's why they ask so much the maid. So a picture is worth 1,000 words. So if you didn't understand, it's really easy because I always explain to my patient with dominoes. So dominoes, it's the end of life. Okay, we all have a number, so we don't know how many. Hope the more to each people, but we don't know. The last domino is the death. So when you see that it's the last dominoes, you're gonna have the increase of refractory symptoms because it's all the process and it's not going very well in the body, So they tend to be very uncomfortable. And you can see that with the time frame that the patient is conscious, and with the natural process, he's becoming more and more sleepy until he's unconscious. So, do you have refractory symptoms? Yes. Okay. Then, are you able to treat them? Yes. Good. You treat. If you're not, and it's refractory symptoms, you can put medication to reduce the level of consciousness without deep sedation. It's called palliative sedation. Okay, you don't have to declare. If the objective is to continuously render the patient unconscious, then it's continuous palliative sedation, and it's under 2 weeks. You must declare. I don't know is it clear? Yeah, okay. So I put two tables here to help. It's like a continuum, palliative sedation, and if you push the medication to unconscious, and the objective is that it's a continuous one. So the patient will be sleepy, mild to moderate sedation. It's a RASS -1 to -3. And the other one we discussed. So I make a summary. You have to use palliative sedation, refractory symptoms. The use of sedative drugs is to relieve the symptoms by decreasing the consciousness, and you must check the prognosis to use the continuous one. It must be compatible with the wishes, of course, and involve all the members of the team and plan the right time. So it's very important that when you decide that you have a team meeting and you explain, and everyone explain what they see about the patient, because they will know that's we have to do. So it's important because people, they can feel not really comfortable if you start it and don't explain. I told that the hydration and nutrition must be considered, but often it's already interrupted because he's actively dying. We have to take long discussion with families, because you'll see that family, when they don't have the contact with the patient, it's like if he's already gone, and it's really painful for them. So you must inform and tell them the goal of the sedation and how long it's gonna last and what they can do. So when they're powerless, I'm giving them power. So you're gonna have to check for the breathing rate and the secretions, and if he seems comfortable. So when they have something to do, it's better. And it's really different from the maid, of course, because the intention is not to kill someone, doesn't cause death. The ethical issues, because there's ethical issues, is mainly because the goal is to relieve the symptoms, because if you remember one patient with existential distress or with very refractory distress, you're gonna know that you have to do something. You see suffering, so you have to do something. So there's an emergency to do something. For existential distress, I take my time because we can afford more time to discuss and try to have more interventions. So it's not rare that I will go talk about him with all kind of subjects and the religious, sometimes it's a priest that gonna help the patient, but he doesn't know it. He's not saying it the first time. And after that, so that's, to know the life of someone, you're gonna know how to treat them. So there's a woman just yesterday, she told me, I'm very afraid, I want a maid. I said, okay, tell me about you. So she's explaining her life, and she had kids, and she said, I have nightmares. I said, oh, you have nightmares, so what kind of nightmares? I think I'm gonna be punished. I said, why? Because my daughter, I didn't protect her. So she was abused, and she didn't say nothing. So she was dreaming and really bad nightmares about it. And I said, how can I help you? She said, I don't know. Do you have a solution to make sure that he's going to understand, meaning God? He will understand that I was not in a condition to help her, and and the daughter, she died because she did suicide. So it was really bad, and she said, but she's there and she's gonna be waiting for me. And I manage with her, and I give medication just for the anxiety, and she was very better after that. But the priest was the main intervention for her, and she said, I'm not religious. I'm telling you, I'm not. But at the end of life, she was scared to death of what she's gonna have. So I said, yeah, doesn't matter, just discuss with someone who's gonna help you. And it really, really did a great job. So don't be afraid, but it takes time. Suffering takes time, and sometimes you don't have time, but you must take the time. Notes in the patient's file and the information to give is very important. So the physician must inform the patient the prognosis related to the illness, and it's going to be irreversible, and the expected duration of the sedation. And you note what's the refractory symptoms, and that you talk with all the team, and that you must make sure that it's really the wishes of the patients, and not, it could be external pressure also. So you must make sure that you know a little bit about the family. I put you some example of the declaration form. It seems a lot, but it's not really complicated. You must write the symptoms and what you tried and the medication that you're starting. And the final form will be probably fill out with another doctor, because if you change, the team, he's gonna have to write if we have to increase the medication, the last dosage, and if the death was okay and comfortable. That's the consent form to use, so the patient can sign, and if it is unfit, you can sign the representative, and that's about it. But types of drugs, so it's really drugs that we use often in palliative care. So it's midazolam that we use often combined with methotrexate for the sedative and painkillers effects. And sometimes we may put phenobarbital. Scopolamine is a good choice also because with deep sedation we can prevent secretion. So and it's sedative, so it can be a way to do a good combination. And the exceptional case is the propofol, but it's really exceptional. You must keep the painkillers during the continuous palliative sedation. So some people, they just, oh no, he's going to be unconscious, so I stop. No. You continue the medication, but you won't use morphine or Dilaudid to achieve the sedation. It's not a good practice. 5, that's good. So that's mainly the medication and the dosage, but of course if you see in a perfusion midazolam 24, it doesn't mean that he's doing a continuous palliative sedation. So you must be careful, it's just a guideline. I put the propofol dosage. That's the monitoring sheet that the nurse will follow and put notes to make sure that the conscious level is well obtained. And I told you that after the patient is comfortable and unconscious, and we were waiting for the natural process, you have to be with the family a lot. So it's really difficult for them, so you have to offer presence and sustain support for them. And as I told you, I give them homeworks, so it's helping them. I'm saying, what kind of person, if I didn't have the chance to know the patient, he's gonna say, oh, he likes wine. Okay, good, bring wine tomorrow. They're gonna do with the sponge, with the wine. It's so cool when he's unconscious, but he's he's responding, you know. So we see that he's comfortable, but still something, you know. And we can say a lot of history and stories about it, because people, we think they're deeply sedated, and son from, I don't know, across the globe comes in the room, hear the voice, tears. It's really, really nice. So that's, with my patient, I take more time with unconscious patient than talking patient. Because if something's wrong, you're gonna tell me, or, you know, basically you're gonna, if it's big. But unconscious, it's not because they're sleepy that it's comfortable. So I'm taking a lot of time, make sure that everything is good. So wine, sometimes with music, they're gonna bring music, so we use different scents, you know. We have different scents, so why not? So some people, they do massage. It's good. It's for all the family, and it's precious time. They will remember that time, and it won't be like a body not moving, you know, like if they're already dead. No, they're still living, but we choose to change the level of consciousness because of very bad symptoms and suffering. You must be careful with the caregivers and your team, because it's difficult also. Sometimes they don't understand, so that's why it must be a team work and a big discussion. And every president of CIUS or CIS of Quebec must include in annual report all the number of continuous palliative sedations, like made. They must, so they're following to see, to make sure that it's very exceptional, and it is. It is exceptional. That's it.